All right, we are ready to begin. Welcome everybody to Cardio. Let's call it Cardney. Let's start again. Cardio-Kidney-Metabolic Challenge, Improving Patient Outcomes. My name is Chuck Vega. I'm going to be your moderator today, and we'll do introductions here shortly. But first, let's get our technology all ready to go. We have a very interactive program today. We are going to gamify this presentation to make it more interesting for you. And I guess we'll show you how that works right now. Oh, no, or not. Okay, but yeah, scan the QR code. If you don't have the Wi-Fi access, there it is, and the password's pretty easy to remember, WAP 2025. As you do so, again, I just want to thank you all for joining us. I know it's early in this meeting. You've got a full day ahead of you. Thanks very well to our online audience as well. So I want to welcome you. You will be involved with the interactivity, so make sure that you play along with us as we go. All right, I think we've got that done. Everybody looks like device is down. Cool. So there's our title. So I am a family physician, a clinical professor of family medicine at University of California, Irvine. So this is my hometown show. Anybody here from Orange County? All right, okay, well, I will show you around. I'll give you a personal tour later. We'll go visit the mouse, then we'll go to the beach. And those are the two best things you can do. Otherwise, I just go to Costco a lot. That's very Orange County. But I'm really pleased to be here. And I'm very excited to be joined by two outstanding faculty, Dr. Jennifer Green and Dr. Ambrish Pandey. Dr. Green, do you want to introduce yourself a bit and tell them about your background?
Sure. Good morning, everyone. I'm Jennifer Green. I'm an endocrinologist at Duke University in the Duke Clinical Research Institute. And the cardio-kidney-metabolic space is my particular area of interest. So I'm excited about the game show, and I wish you all luck, and I hope you all are winners.
You're all winners just by being here.
That's right.
Dr. Pandey, go ahead.
Thank you. Good morning, everyone, and thanks for being here. I am Dr. Ambrish Pandey. I'm a cardiologist and associate professor of internal medicine in the Division of Cardiology and Geriatrics at UT Southwestern. I direct the Heart Failure with Preserved Ejection Fraction program and lead the Cardio-Metabolic Research Unit. I'm delighted to be here and looking forward to this exciting event.
Awesome. Thank you very much for being here. So here's our agenda for today. We'll be doing our introductions, and then we'll be talking about the game in just a second here. Jennifer's going to focus on chronic kidney disease and diabetes, looking at the use of a non-steroidal mineralocorticoid antagonist in terms of how to manage that important condition. Then we'll be moving into heart failure, and we'll be combining. So, I'm in family medicine. I'm here to create synergy. And, through this deck, you're going to see the synergy between these conditions. And if you don't, we're going to tie it together with 3 cases at the end. So this will be interactive between us, but it's also interactive for you as well. Please put in your questions. And if you have some salient, beyond questions, if you have pearls that work in your own practice, things that you found that really can help to improve patients' care with this very common disease state, absolutely put those in. I'll try to get to as many of those as we can at the end of our session. So before we begin with Dr. Green, I know we want to introduce the game, so let's get that set up. Can we run that animation, please? You'll see on your tables, you are heart guardians or you are kidney keepers on your tables. But we can't have favorites, we're objective, but I think we all prefer Ion Masters. That's the online crew, so you're the Ion Masters. Definitely somebody who was watching a few Marvel movies before they made these names, and I think the Ion Masters has some sticking power. All right, so make sure that when Dr. Green, Dr. Pandey, and myself are asking the questions, try to respond and do your best, because that we'll tally the results at the end and see who wins. All right, with that, Dr. Green, please take it away.
Thank you. I'm going to have to stand up because I can't see. All right, I'm going to
go.
talk a little bit about chronic kidney disease, specifically in patients with diabetes. All right, first question. What is the estimated prevalence of chronic kidney disease among adults with diabetes in the United States? All right, 1%, 20%, 40%, or 60%? I need to hit.
No, the Guardian is really, I don't know, that doesn't look like a confident response.
He looks dejected. Okay, so the most popular answer was 40%, selected by 59% of participants. All right. Very good. Very good.
Yeah.
So yes. So the prevalence of chronic kidney disease in US adults with type 2 diabetes shown here between 2003 and 2018. On the right-hand side shows that among people with diabetes, prevalence is somewhere between about 30 and 40%, 40% a little earlier. I don't know why the prevalence is coming down. That's not necessarily what I would expect to see unless we're doing a better job in diagnosing diabetes earlier before people have had the chance to develop complications. That would be a really optimistic view because I don't think that chronic kidney disease is a condition that's going away. And you can see, of course, that people without diabetes also have CKD, but the rates are far lower.
Well, Jennifer, I think it's really, I am going to give us credit for managing diabetes more effectively and hypertension as well, which are two main risk factors. But it's kind of remarkable in the light of the graying of the population, too. Just by age, the prevalence of CKD gets older. As the mean age gets older, we should see more, not less CKD. So good job, everybody. And we'll keep going.
Okay. And just a reminder, I'm sure you've heard this before, but there's a very close interrelationship between diabetes, kidney, and cardiovascular diseases. And I see patients primarily at a veterans hospital, and I have to say that most of my patients have had diabetes for a long time, and most of them have some evidence of kidney disease, and many also cardiovascular disease. So these are conditions or comorbidities that are present together in a very large proportion of people. And the problem with that is that these are not unrelated risks. So if you have, for example, diabetes and heart failure, your prognosis is worse than someone who has only diabetes or who has only heart failure. So these are independent risks that are conveyed. And although the traditional means of addressing risk factors, such as for people with diabetes, glucose control, blood pressure management, lipid management, remain really the foundation of care for reducing risk in patients with CKM diseases. We know that even when we apply these therapies optimally, there's still a significant residual risk. So that even with these traditional modalities of risk reduction, we don't reduce the risk of adverse events to that of people without these conditions. So there's a lot of room for improvement. Now, one thing to think about is that these are also complications or comorbidities, cardiovascular and kidney diseases, that follow a similar timeline. They're not really necessarily happening on independent timelines. They're very closely linked. And this, as shown in this cartoon, some of the early cardiovascular abnormalities that can occur associated with hypertension, volume overload, progressive LVH, and then progressing to a bit more clinically evident stage of disease. So for example, clinically evident evidence of kidney disease, which would be associated with cardiovascular problems such as subendocardial ischemia. And then there's a variable timeline over which people with those conditions might progress to end-stage kidney disease. And that's a stage of kidney disease where we know the risk, for example, of sudden cardiac death is very high. Another thing that's really important to understand when it comes to the risks associated with chronic kidney disease is that about 10% of people with chronic kidney disease will actually progress to dialysis. And what happens to the other 90% is during that long timeline to progression to end-stage kidney disease, most people unfortunately will die of cardiovascular events or complications. Whoops, sorry, I get it, don't cheat. And I show these data a lot, and these are really interesting data because it's very, very difficult, in fact, to find information about what the impact on life expectancy might be of having kidney disease, cardiovascular disease, or both. And this is very fine print, but I would draw your attention to, let's say, the third blue bar from the left. And what that shows us is that for women with type 2 diabetes who are 40 years of age, if they have moderate chronic kidney disease, the expected decrement in their lifespan is on the order of about 25 years. So when these things happen, and they happen early, it's an even bigger risk to young people. Now, if you move further in, I think to maybe the sixth blue bar in, it's that same group of women 40 years old with type 2 diabetes with moderate chronic kidney disease, and then also some form of heart disease. the expected reduction in life expectancy for groups of women like that would be closer to 30 years. Now, of course, each individual person's trajectory will differ, but I think it's very important that we understand that when these conditions occur early, those are not patients who are at low risk. Those are patients who are at the greatest risk for adverse outcomes, and it is important for us to detect and treat these conditions as soon as possible. All right, next question. Which of the following patients should be screened now for chronic kidney disease, including measurement of both eGFR and UACR, urine albumin to creatinine ratio? Is it anybody with newly diagnosed type 1 or type 2 diabetes? Is it someone with newly diagnosed type 2 diabetes? Someone with newly diagnosed type 1 diabetes? Or someone diagnosed with type 1 diabetes 2 years ago? All right, you should know this.
While you're answering that, screening involves two important components: it's blood and urine. eGFR important, UACR important. They are synergistic in increasing risk. So if you have both, it's actually a worse renal and cardiovascular risk than having either one. So we really want to be thinking about screening both, and we're not doing a great job of getting the urine in particular on a routine basis.
Yeah, no, we're not. I would say the best data that we have suggests that only somewhere between 10 and 40% at best of people are actually getting a UACR checked once a year in the United States. And that is something that's recommended for everyone with type 2 diabetes. And that's been recommended for decades. This is nothing new or different, and it should be covered by insurance.
No problem.
So the correct answer for this is actually someone with newly diagnosed type 2 diabetes. The most popular answer was kind of the most aggressive screening approach, but I'll tell you why somebody with newly diagnosed type 1 diabetes doesn't need to be screened right away. But for type 2 diabetes, that is absolutely correct. Whoops, we're going to see it again. Sort of a little bit backwards. I think you could see the results.
Yeah, I think that's
yes. Yeah. Okay, so a reminder that both the ADA and KDIGO guidelines recommend that for someone with type 2 diabetes, you start screening for complications immediately when that diagnosis is made. And that is because people with type 2 diabetes often have had some degree of hyperglycemia for up to 10 years before the diagnosis is made. And they also have many other risk factors for kidney disease. They often have excess weight, hypertension, dyslipidemia. And so a meaningful proportion of people will already have kidney disease, or retinopathy or peripheral neuropathy is very common at the time that they're diagnosed with type 2 diabetes. Now with type 1 diabetes, because that is on a much more accelerated timeline, when people are diagnosed with type 1 diabetes, they've often only been hyperglycemic for a short time. And so they've not had enough exposure to hyperglycemia to have developed diabetes-related complications. So you can wait for 5 years to start screening for CKD in someone with type 1 diabetes. Just a reminder that we screen, as was mentioned earlier, with both the eGFR and the urine albumin to creatinine ratio. And a single abnormal value does not a diagnosis of CKD make. You need to repeat it. A CKD diagnosis would be that either the UACR or eGFR is abnormal for at least 3 months. So sometimes the UACR will be up a little bit for one reason or another. It needs to be persistently high for it to be a diagnosis.
So question for you, I'm sure you see a lot of diabetes type 1.5 or latent autoimmune diabetes of adults, or LADA. I've been screening those individuals while I'm trying to figure out, what their status is. These are new patients with hyperglycemia. I usually will send them for a UACR, when I'm trying to figure out what they have, because I just don't see a lot of harm in it, and and they might have had, longer standing hyperglycemia previously, asymptomatic.
And we see a lot of people with somewhat atypical presentations.
Right.
And many times by the time you start to think, oh, maybe this person, because they've failed oral medications,
right.
For example,
for those patients,
you start thinking, oh, maybe this person seems to need insulin after a fairly short period of time. Maybe this is more type 1-ish. Absolutely. If it's a gray area, you don't know how long this problem has been going on, it's not a problem to be a bit more aggressive with your screening. And I have to say, too, that many people with type 1 diabetes now have a phenotype that's a bit more like type 2. And I'm sure you've seen that as well.
Right.
Yeah.
Jennifer, I had a question as well. So diagnosis is really important, but when do we repeat the testing if it is not positive for CKD in both type 1 and type 2 diabetes.
Okay, so if the lab results are normal, then it needs to be done at least once a year. Okay, so once a year is what is expected and what should be reimbursed by commercial insurance or government.
And I don't want to interrupt your flow too much,
Sure.
but I think the other thing that we should also bear in mind is that when you see changes, GFR is decreasing, and it's fine to check GFR and UACR more than once a year, because not all kidney disease is diabetes and hypertension. There may be another factor going on, so it's perfectly fine, especially if somebody's not doing as well, to check more frequently, and that's usually going to be accompanied by a referral to nephrology.
Absolutely. So
And further testing,
yeah,
ultrasound, et cetera.
In particular, the more abnormal the labs are, the more frequently they should be reassessed, and that's pretty clear from the KDIGO guidelines. You bring up another point that not all kidney disease and diabetes is diabetic nephropathy. And so, for example, if the person's kidney disease is accelerating very rapidly, and or if they have an active urine sediment, let's say they have a lot of red cells or red cell casts, then we do need to keep in mind that there could be another process going on, like a glomerulonephritis, that needs to be treated completely differently. So this is a good opportunity for us to, I put on my internal medicine hat and make sure that I'm not missing something, because it's easy to attribute everything that happens to a person with diabetes to diabetes, and it's just not always the case. So just to reiterate, these are data from people with type 2 diabetes, and you can see generally this is from 2016, so this might be actually the data from contemporary populations maybe in fact look a bit worse, but at that time about 7% of people with newly diagnosed type 2 diabetes had evidence of kidney disease, and you can see it increases over time. The number one risk factor is duration of diabetes as far as the risk factor for the prevalence of or the development of chronic kidney disease. Okay, now sort of a physiologic question. So which of the following is considered a key driver of CKD progression in diabetes? Is it inflammation? Is it acute kidney injury? Or is it genetic variants?
All right, how are animations doing?
I know, the heart guardians are always like
really
phoning a friend.
searching for the answer all the way
Yeah.
behind him.
I feel like they're trying to look into kidney keepers.
Yeah, he's asking them, he's getting a consult from
Yeah.
nephrology. I haven't seen that Ion Masters. Okay, excellent, excellent. So although these are all potential contributors to the development and progression of kidney disease, inflammation is considered to be really one of the 3 key drivers, and this is a fairly recent concept. We've always known that both systemic and intrarenal hemodynamic dysregulation contributes to the development of cardiovascular and kidney disease. And of course, hyperglycemia or other dysmetabolic states can contribute to the development and progression of kidney disease as well. But inflammation probably plays a very, very significant role. The problem is we didn't really have much to do to address that driver in the past. There are many ways in which chronic inflammation can affect, as shown here, the glomerulus. And this cartoon shows that chronic inflammation can affect many of the main components of the glomerular filter, including the fenestrated epithelium, the basement membrane, and I think there's a typo here, the mesangium. So there are a variety of different ways in which inflammation can cause over time, organ fibrosis and kidney dysfunction. So this is a major issue for the development of kidney disease as well as cardiovascular disease, because these are so closely linked.
Yeah, once you see that remodeling of any organ, I think of lungs and the bronchus in smoking, asthma, COPD. It's inflammation is just really rough on the body, and especially over time, it's going to yield structural, not just physiologic effects, but structural effects, and that's where the UACR comes in. You're literally losing protein because your anatomies have been changed.
Yeah, I think that's just the body's response to chronic inflammation in given organs, and we see this in the heart, the kidney, and the liver as well. So this is a universal problem. One of the key contributors to this both systemic and organ-specific inflammation is considered to be overactivation of the mineralocorticoid receptor in the mineralocorticoid system. And when the mineralocorticoid receptor, which I may abbreviate MR at times, is activated, then that results in increased production of pro-inflammatory cytokines and pro-fibrotic mediators. And you can see that in turn, as we've mentioned previously, that can result in a variety of different features of kidney damage, also vascular damage and heart damage as well. So again, these are systemic and organ-specific processes that are key drivers of dysfunction and that we would like to be able to address effectively in the regimens of care that we devise for our affected patients. So this is a slide. I just want to remind everyone that the mineralocorticoid receptor, of course, can be activated by aldosterone, but that is not the only substance that can activate the MR. That's sort of the one we think about most often. The other thing that I want to make sure I mention on this slide is that when we talk about overactivation of the MR, oftentimes people get the impression that this is a problem only for people with high aldosterone levels. That is not the case. So you don't need to identify overactivation of the mineralocorticoid receptor by documenting that the aldosterone level is high. That is not necessary. When patients have diabetes, kidney disease, cardiovascular disease, we know that this is happening and you don't need to do additional laboratory tests to make a diagnosis. There are a variety of other substances that can activate the mineralocorticoid receptor, including cortisol, oxidative stress, hyperglycemia, and other signaling proteins like RAC1. And this is a busy cartoon, but essentially what this is just showing is that finerenone, a new and unique non-steroidal mineralocorticoid receptor antagonist, of course, can block the activation of the MR by substances like aldosterone, but it's actually not specific to aldosterone, so it could minimize the activation of the MR from those other substances that I had mentioned as well. And then, of course, effectively mitigating the inflammatory response to MR overactivation should in turn have beneficial systemic and organ-specific effects. A reminder before we move on to the next section that finerenone, again, a non-steroidal mineralocorticoid receptor antagonist, has been shown in people with chronic kidney disease and type 2 diabetes to significantly reduce the risks of both important cardiovascular and kidney outcomes. And this shows us the results of the Fidelity pooled analysis, which includes data from the Fidelio and Figaro trials, each individually, very large long-term studies enrolling patients with type 2 diabetes and chronic kidney disease. One of the trials focused on cardiovascular outcomes, the other focused on kidney outcomes. But because the way that the data were collected about the patients and the way the events that occurred were collected in a similar fashion, it really allowed the authors and the investigators to pool the data into this very highly powered Fidelity analysis. And what they found was that the effect of finerenone compared to placebo when added to otherwise standard of care for patients with type 2 diabetes and chronic kidney disease very significantly reduced the risk of a composite cardiovascular outcome that was comprised of cardiovascular death, MI, stroke, and hospitalization for heart failure. That's in the top, and you can see that the individual outcome of heart failure hospitalization was significantly reduced with finerenone compared to placebo. And then in the bottom two sections, what you can see, the next two sections are the impact of finerenone on two different composite kidney outcomes. The one at the top is the more stringent outcome, which included progression to kidney failure, a sustained at least 57% decrease in eGFR from baseline, and kidney-related death. And again, you see a very significant reduction in the risk of that composite kidney outcome. There was a nominal but not statistically significant reduction in death from any cause, and the point estimate for hospitalization for any cause was favorable, but again, this was not a statistically significant difference.
So, yeah, that's great. Thanks for the powerful summary. And we will be getting into treatment towards the end with our cases. So if you're wondering, well, I think one of the important things to note is this is in addition to other evidence-based care for folks with CKD and diabetes. And we'll talk about that towards the end and kind of put it all together for you. But now, let's go ahead and check our leaderboard. Let's see who's up in the lead. We have, it looks like Ion Masters with our top score so far but it's a really tight race between kidney keepers and heart guardians. Don't worry, we have plenty of questions ahead, so you can catch up. There will be time. And so, yeah, and I think otherwise, let's get going. And Amber, you want to take away with your section?
Yes, thank you so much.
You get the flashing lights, too. Oh, no, they took them away.
Thanks, Jennifer. That was really great to hear about the overview of the kidney health. And now, just switching gears and focusing on heart failure, another important component of the cardio-kidney-metabolic dysfunction that we often encounter in our aging population. So I'll start with the first polling question, which is basically referring to the current guideline recommendations for heart failure risk screening in individuals with type 2 diabetes, and we have to identify what are the current recommendations for the same. Option 1 is no screening is indicated if there are no symptoms of heart failure and a normal physical exam. Option 2 is yes, but screening should be done with echocardiography first, and NT-proBNP is only useful for diagnosing symptomatic heart failure. Option 3 is screening for heart failure is recommended with natriuretic peptide testing, and if elevated, proceed to echocardiography to identify stage B heart failure and enable early intervention. And option D, or fourth option, is no screening unless a patient develops symptoms, as there is no proven benefit to detect asymptomatic heart dysfunction. So please get busy with the answers and let us know what you think. Have the heart guardians get this one right. Yeah. Okay. All right, so really I think we have our answer, and the most common response was the correct response, which is screening for heart failure is recommended with NT-proBNP testing. If elevated, there is recommendation to proceed with echocardiography to identify stage B heart failure and enable early intervention. So that was chosen by 60% of the audience, and that is the correct answer. So congratulations on getting that right for the most of you guys. So let's take a look at how the diabetes or any other cardiometabolic risk factors lead to development of heart failure. And as we know, risk factors like diabetes take a lot of time in development, and then the progression to heart failure does not happen in a single step, but it is actually a multi-step process involving sustained myocardial stress, myocardial injury, and remodeling of the left ventricle that leads to what we call a stage B heart failure, where you can have cardiac structure and function abnormalities like left ventricular hypertrophy, abnormal remodeling pattern, impaired relaxation, or what we refer to as diastolic dysfunction. And that eventually progresses to stage C, or clinical heart failure, where you see the overt signs and symptoms of shortness of breath, fluid buildup, and other things. And NT-proBNP, which is a biomarker of neurohormonal stress upregulation, is often elevated not in just stage C patients with signs and symptoms, but also in stage B heart failure when the cardiac stress has already happened and the heart is already showing the signs and symptoms, showing the evidence for development of the heart stress. There have been a lot of research around early identification of this abnormal neurohormonal upregulation, and a threshold of over 125 picogram per ml for NT-proBNP represents an optimal cut point that has been associated with increased risk of death or unplanned cardiovascular rehospitalization, as shown in this slide here. So in the table, we have the measures of the performance at different thresholds. And as you can see, for a level of 125, we had a high sensitivity of up to 0.8 and a specificity of 0.6, and a pretty good accuracy of around 61%. And these data are coming from a prospective observational study of over 600 patients with type 2 diabetes. And as you can see on the right side, and the cumulative incidence curve, there is a really good separation between the two curves showing NT-proBNP levels over 125 with the dotted line or the dashed line, and NT-proBNP levels less than 125 with the continuous line. And you can see there is almost flat trajectory for the lower levels of NT-proBNP and a much higher risk of death or unplanned cardiovascular hospitalization shown on the y-axis among those who had an elevated NT-proBNP over 125 picogram per ml, highlighting the value of this biomarker to identify high risk for future adverse cardiovascular event. And why does this matter? Why does screening matter? Screening matters because there have been trials that have shown that a collaborative care for modifying cardiovascular risk in patients who have been identified by screening actually reduces the risk of future adverse cardiovascular events. These data come from the very landmark trial called STOP-HF trial, in which the patients were randomized to NT-proBNP guided screening. Actually, it was a natriuretic peptide or BNP guided screening versus usual care. And then the cumulative incidence curves show the control group by the continuous line and the intervention group by the dotted line. And what they saw was that among people who were screened by, with BNP levels or brain natriuretic peptide levels and then had a collaborative care, there was a greater, there was a much lower risk of adverse cardiovascular events, as shown with the odds ratio of 0.69. And this was largely driven by greater uptake of RAS-modifying therapies in the intervention arm that had the natriuretic peptide-based screening, suggesting that early screening can lead to greater use of evidence-based therapies and indeed lower the risk of major adverse cardiovascular events. So based on these data, now the current guidelines actually do recommend natriuretic peptide screening, and this is a Class 2A recommendation in the American College of Cardiology, American Heart Association, and Heart Failure Society of America recommendations for patients at risk of developing heart failure. Natriuretic peptide biomarker-based screening is recommended, followed by team-based care, including a cardiovascular specialist for optimizing guideline-directed medical therapy and reducing the risk of development of heart failure in these patients. So let's come to the next polling question, and which is, which of the following statements about epidemiology of heart failure with preserved ejection fraction, which is a subtype of heart failure, is most accurate? First option is HFpEF, or heart failure with preserved ejection fraction, accounts for 20 to 30% of all heart failure cases and is more common in younger adults. Second option is HFpEF represents approximately 50% of all heart failure cases and is more common in older women and is associated with hypertension, obesity, AFib. Third option is HFpEF has a significantly better prognosis than heart failure with reduced ejection fraction, the other heart failure subtype, with a very low mortality rate. And the last option is HFpEF is primarily caused by ischemic heart disease and is more prevalent in men under 60 years of age. So let's get busy and choose the best and the correct option here.
So that's great. Great start, Ambrish, and let you guys answer, so please do. But a couple questions came in on NT-proBNP, so it might be worth to address them now. Do you adjust it for things like age, weight, or prevalent chronic kidney disease?
So I think that's a great question, and NT-proBNP levels have been associated with each of these factors. It goes up with age, and it goes up when you have kidney function abnormalities, and it is lower in patients who are obese. So there are adjustments in the levels by age for diagnosing heart failure hospitalization or diagnosing individuals who have signs and symptoms. But for screening, the levels are not adjusted because 125 is very strongly associated,
high,
regardless of different subgroups, as you highlighted.
Great.
So for screening, no adjustment. For diagnosing in the emergency department or in the hospital, there is an adjustment for age particularly.
Thank you.
All right, the answers are in, and as you can see, let's go back. All right, this is a little. So as you can see, the correct option was chosen by majority of you, again 60%, that HFpEF represents 50% of all heart failure cases, is more common in older patients, more common in women, and is associated with risk factors like hypertension, obesity, and AFib. And the reason we're talking about HFpEF now is because it is indeed the most common, but also the one type of heart failure that is growing in prevalence over time. Let's see. So this pie chart here shows the distribution of HFpEF among all heart failure cases from a cardiovascular health study, which was a community-based study of older adults. And as you can see here, 54% had normal ejection fraction, suggesting that it was the most common phenotype of heart failure in this community-funded study. This has been further confirmed in several other community-dwelling population cohort studies, and particularly among older women, 80% of all heart failure cases that occur are indeed HFpEF or heart failure with preserved ejection fraction. If you look at the lifetime risk of HFpEF, this is looking at developing HFpEF by age of 90. If you look at individuals who are middle-aged at around 45 to 50, the lifetime risk of HFpEF is comparable in men and women, and it's up to 12 to 14%. And what that tells us that 1 in 10 individuals at the age of 45 are at an increased risk of developing HFpEF, and thus highlights the high risk that we see as our population ages. The data here show the growing burden of HFpEF in our community. These data come from the ERIC surveillance cohort study. On x-axis, you have time, and this is only till 2014, but the trend has only continued to worsen. On y-axis, we have the event rate, and you can see here across all sex and race groups, you have an increasing burden of heart failure hospitalization of all types, shown by the black line. But particularly, this trajectory is much worse for HFpEF, which is shown by the blue line, where for HFrEF, the trajectory seems to be more plateaued or more flat, suggesting that the growing burden of heart failure in the community is indeed driven by the high rates of hospitalization for HFpEF. And the reason it is really important to look at HFpEF and identify HFpEF is that the mortality risk and the outcomes that we see in patients with HFpEF are just as grim as it is for heart failure with reduced ejection fraction when you have an impaired pump function or low ejection fraction. These data come from the Rochester, I think, epidemiology cohort, and on x-axis you have time, on y-axis you have survival, and you can see both the curves, the red curve for HFpEF and the black curve for HFrEF, are nearly overlapping, suggesting that the risk of mortality is really high for both HFpEF as it is for HFrEF. And thus, it's really important to understand what drives HFpEF, and is it really different between HFpEF and HFrEF among the drivers or risk factors. And as we were talking about earlier, some of the common risk factors for HFpEF are age, high blood pressure, obesity, having hypertension, which is often captured by antihypertensive medication use, prior history of myocardial infarction or ischemic heart disease. And these are not too different from HFrEF either. These data come from, I think, Framingham Heart Study and some other cohorts. And as you can see, a lot of the similar risk factors drive the risk of HFpEF and HFrEF, which indeed means that if we can control these risk factors and focus on a lot of these risk factor control, which are along the cardio-kidney-metabolic risk factor spectrum, we can indeed lower the risk of both HFpEF and HFrEF in our community. So let's come to our third question, which is focusing on pharmacological interventions. So which of the following pharmacological interventions have shown the strongest evidence for reducing cardiovascular death and heart failure hospitalizations in patients with heart failure with preserved ejection fraction? Option 1 is ACE inhibitors or angiotensin receptor blockers as first-line therapy. Option 2 is beta blockers for all patients with HFpEF, regardless of comorbidities. Option 3 is SGLT2 inhibitors and finerenone that Jennifer talked about a little bit earlier. And option 4 is digoxin for heart rate control and symptom relief. So let us know what you think, and then we'll discuss more.
Yeah, great job answering the questions. I will fill the space with another question, and feel free for everybody to contribute here, because there's multiple questions about how do you get brain natriuretic peptides, BNPs, covered in screening, and that can be a challenge. I'm happy to address it, but if you have any tips, because I know I've experienced that same challenge in my practice.
No, that's a great question, and I think we have actually got screening programs that are undergoing right now in my health system as well, and this challenge has come up, particularly for screening in primary care setting, right, and screening in routine clinic visits for wellness, for diabetes. And I think the biggest learnings that we have had is all about like documentation for why you were screening.
Right.
Second, linking it with the right ICD-10 code. So often what we have seen is that when you link the screening test with the diagnosis code of at risk for heart failure or screening for heart failure, they often go through, and there are not as much denials by prior authorizations. So if you link it for diabetes, it may not go through, but you have to link it for the right ICD-10 code. And that has been a lot of our education for primary care doctors in my practice. And we see over 90 to 95% screening tests being covered. So that's what my experience has been. Jennifer, please feel free to share your experience. And then we can
Anything to share, Jennifer?
Well, again, I work in the VA system, and
Right.
so it's a little
You're
different.
regimented.
And to be honest, though, the group that I'm screening, many of them already have heart failure, and then a large proportion are also at risk for heart failure already due to their comorbidities. So I haven't had a lot of pushback, but it's going to be different outside of a system like that.
My only thing to share is that many times you'll find these patients do have exercise intolerance, they do have fatigue, and so I code those up too because those are just so incredibly common, and they could also represent HFpEF, right?
Yeah, and a lot of the times, unless you ask the patient, they may not complain about it because they often attribute it to their age or deconditioning. And indeed, those can be signs of underlying heart failure waiting to be unmasked. And I think that's why it's really important to have a detailed history, document the symptoms if they exist, and link it with the right diagnosis codes. I think that I cannot emphasize enough because we have seen that makes a huge difference in the coverage in our health system, at least.
And so, I think a lot of my patients, they won't necessarily complain of exercise intolerance, but what they've done is that they have just continually reduced their activity so that they don't become symptomatic. So that's something that can be difficult to understand unless you specifically ask.
That's exactly right. So I think let's go back to the polling results because I think most of you guys did get the polling results correct. It was option C, I believe, which was use of SGLT2 and finerenone based on the recent evidence that has come out in the past few years, and that we'll be looking at in more detail in the next slide. So SGLT2 inhibitors like empagliflozin and dapagliflozin have been studied in patients with heart failure with preserved ejection fraction. EMPEROR Preserved was one of the seminal trials that came out first, and it demonstrated a 21% reduction in risk of cardiovascular death or heart failure hospitalization. The data are shown on this slide here. On the left, we have the cumulative incidence curve with time on the x-axis, cumulative incidence on the y-axis. Placebo group is shown by the blue line, and the red line shows EMPA. And as you can see, there's a clear and early separation of these curves, highlighting a very quick benefit that you can get from these therapies. And the difference is quite substantial with a hazard reduction of 21% and a p-value of less than 0.001. And the benefits are not just limited to a specific ejection fraction subgroup. The curve on the right shows the treatment effect across the distribution of ejection fraction, ranging from heart failure with reduced ejection fraction, EFs like 15, 30, and less than 40%, to as high as 75%. And as you can see, there is no effect modification for the treatment benefit of empagliflozin in heart failure across the spectrum of ejection fraction, suggesting that it's actually a very foundational therapy or considered now one of the pillars for treatment of heart failure regardless of the ejection fraction, and particularly in HFpEF where we don't have as many therapies available, it is one of the first line agents that we use now. Similar to empagliflozin, we saw consistent pattern of risk reduction, 18% risk reduction with dapagliflozin in the trial, DELIVER trial. And again, the same kind of data are shown here. The cumulative incidence curves also separate early. The effect is also consistent across the ejection fraction distribution. And now you have very convincing data from two different trials using two different SGLT2 inhibitors, highlighting that this is indeed a class effect of this therapy, which was initially developed for diabetes, for patients with heart failure and heart failure with preserved ejection fraction. So empagliflozin and dapagliflozin or SGLT2 inhibitors are our first line agent for treatment of patients with HFpEF. Now coming to finerenone, Jennifer talked about finerenone earlier, how it's so critical for patients with diabetes and CKD. Recently, the data from Fine Arts heart failure trial were published, which was looking at finerenone in patients with heart failure with mildly reduced or preserved ejection fraction. The ejection fraction cutoff used in the study was 40%. And as you can see here, we showed different cumulative incidence curves for the primary outcome of total worsening heart failure or death, secondary outcomes of just total worsening heart failure, just death from cardiovascular causes, or the first heart failure event. And overall, there's a consistent pattern of reduction in risk. Again, there is an early separation of the curves. It happens by as early as 28 days. Placebo is shown by the blue line, finerenone by red line, and you can see there's a significant 18% reduction in risk of primary outcome of worsening heart failure or death, highlighting its real impactful role in reducing risk of adverse cardiovascular events. So this is the only trial in patients with HFpEF with finerenone. There are a couple other trials ongoing, so we will have more evidence come through. But alongside SGLT2 inhibitors, now the FDA has approved finerenone for use in patients with heart failure with preserved or mildly reduced ejection fraction. And one of the best parts of finerenone in HFpEF was that the efficacy of finerenone was consistent across all subgroups, no matter how we looked at it among patients with and without diabetes, with and without CKD, obesity. The pattern of treatment effect was consistent, and it was effective in all patient subgroups, again highlighting its primary, I think, role as one of the key foundational therapies for treatment of patients with HFpEF. So I'll stop there, and then we can check the leaderboard.
Yeah, let's check it out. Let's see if we've gotten things a little bit closer, if the Ion Masters are still, they've fallen. They're no longer Masters.
Our guardians have proven that they are indeed Masters of the Heart.
Yeah, that's great. They made a great comeback. They took that title seriously, I guess. All right. So no, great job, guys. That's awesome. Way to come back. All right. And he's very proud of himself.
So that's good. Yeah.
He's very, very proud of himself. All right, so let's now move and switch gears a little bit. Now we're going to do some cases which will frame up and I think put some of the great discussion we've had so far into context. And so 3 doctors, 3 different cases, and Jennifer, you're going to lead us off, I guess.
Okay, yes, I'm going to do something maybe a little bit different than what you would have expected. So this is a case of a person with type 1 diabetes and chronic kidney disease. So she is a 46-year-old woman, and she's had type 1 diabetes for 20 years. She also has hyperlipidemia and hypertension, and she's been recently diagnosed with chronic kidney disease. At the visit today, she looks well. Her blood pressure is 134/70. So her medications at present include multiple daily insulin injections. She's on atorvastatin. She's on losartan, 25 milligrams daily. She has an A1C of 7%. She has an eGFR of 53. Her UACR is moderately elevated at 180 milligrams per gram, potassium 4.2, and you can see her lipids shown on the screen. All right, for this patient with type 1 diabetes and chronic kidney disease, what is the next best step to delay the progression of her kidney disease? Is it changing her to an insulin pump therapy? Is it an SGLT2 inhibitor? Is it up titrating losartan to the maximum tolerated dose? Or no change? Is she doing well as she is? All right, let's see if the heart guardians get this one. Okay, actually, the most commonly chosen answer is the SGLT2 inhibitor. Well, officially and based on the guidelines, in fact, that would not be the next best step for someone with type 1 diabetes. At present, though, the recommendation for everyone with chronic kidney disease, irrespective of type 1 diabetes, type 2 diabetes, or other conditions as the cause, is in fact to up-titrate their dose of ACE or ARB to the maximum tolerated dose. And that is not an approach that those of us who are not nephrologists have generally been doing. For endocrinologists, what we have done in the past is we screened people with diabetes for chronic kidney disease. If they had it, we made sure they were on an ACE or ARB, that their blood pressure was controlled, and then we were like kind of done. We just watched their kidney disease get worse. In fact, we are supposed to be up-titrating the dose of ACE or ARB to the max tolerated dose, and certainly in people with kidney disease, to get their blood pressure less than 130/80 millimeters of mercury. Now, she's close to that, but she is a young person. She's going to be living with kidney disease for many, many more years, and it's important to make sure that her blood pressure is adequately controlled. And in fact, a target blood pressure of lower than that might be reasonable if it is tolerated. So trials of ACE or ARB therapy at max tolerated doses in patients with lower levels of albuminuria, so between about 30 and less than 300 milligrams per gram, have found that that particular therapy reduced progression to more advanced albuminuria, reduced CKD progression in other respects, and reduced the risk of cardiovascular events. So what does maximum tolerated dose mean? So the nephrologists have a very different opinion from the rest of us, and I've learned. So essentially, a max tolerated dose means they don't have symptomatic hypotension. It means that they don't have unmanageable hyperkalemia, and it means that their eGFR has not decreased by more than 30%. A reduction in eGFR with max tolerated dose of ACE or ARB of up to 30% is actually considered by nephrology to be evidence of a beneficial hemodynamic effect of that intervention. Now, if the eGFR drops by more than 30%, then you start to worry that there might, in fact, be an acute kidney injury going on. But in fact, we want to see the eGFR drop because then it's evidence that there's going to be a favorable hemodynamic effect of the therapy. So if you take anything away, I would say that's what I've learned and have applied most often in my clinic over the last 5 years or so that I've been working closely with our nephrology colleagues. So you can still address this issue effectively in people with type 1 diabetes, although unfortunately don't have quite as many tools available right now to address the other key drivers, so inflammation, and we certainly can address hyperglycemia, but that's very insulin specific. Now, many of you picked SGLT2 inhibitors. At present, people with type 1 diabetes and chronic kidney disease have been enrolled only in trivial numbers in any of the outcomes trials, and therefore we have very little information about the efficacy or safety of use of SGLT2 inhibitors to mitigate the progression of CKD in people with type 1 diabetes. So we can't recommend that at present, but it's possible that more information will be available in the future. I do want to let you know that the results of the FINE-1 trial are expected to be presented in early November of this year, and this is a specific trial of finerenone in people with type 1 diabetes and chronic kidney disease. And it's a pretty simple design. It's going to enroll about 220 people with type 1 diabetes and chronic kidney disease. They're going to be randomized to the addition of finerenone or matched placebo, followed for 6 months. And the primary outcome is the change in UACR from baseline over that 6-month period of time. And reductions in UACR are associated with delayed progression of kidney disease and actually reduced risk of cardiovascular events in patients with chronic kidney disease. So this is considered to be a clinically meaningful surrogate outcome in patients with chronic kidney disease. So stay tuned. It may be that very soon we have an additional treatment option.
That's great. No, so really a question for either of you. I really like the idea of using ACEs or ARBs to the maximum tolerated dose. I certainly try to do it. They're not very strong antihypertensive drugs, and just because the number looks low, and I'm always having them check blood pressures at home too, if they're not symptomatic and their blood pressure is still in the 90s over 60s, I think there's still a benefit there. But hyperkalemia can be more difficult to work around.
It sure can.
Is there a benefit to, I also see a lot of patients on lisinopril 5 milligrams, losartan 25 milligrams. Is there a benefit there if that's really all you can do, or is there really no point in taking such a low dose when it comes maybe either to heart or kidney outcomes?
That's a good question. I mean, for many people, the max tolerated dose of an ACE or ARB is 0, right? So if you, so there are some people who simply can't take these drugs for whatever reason, and that's okay. And those people have, in fact, been enrolled in the CKD outcomes trials with that understanding. We don't want to exclude them. In fact, they're the people who really have a great need for these newer therapies.
Right.
So they've been enrolled in these trials in fairly low numbers, but we know that that can happen. So one thing I would mention about hyperkalemia is, of course, we always, at least traditionally, have checked potassium after starting somebody on an ACE or ARB, primarily due to concerns that we might unmask something like renal artery stenosis, right? And then they're going to have a much more exaggerated response than we expect in the general population. I don't see a lot of hyperkalemia with ACE or ARB therapy in my patients, even when I up-titrate the dose. But this is an opportunity, I think, to talk with our patients about their diet, which I do all the time anyway, because of I'm addressing their diabetes, their hypertension, their dyslipidemia, and just to kind of make sure, especially the summertime is a big problem in North Carolina because people will just kind of eat big bowls of fruit all day.
Right.
And, that's not a great choice for their diabetes, but it also, that can have a lot of potassium. So really moderation in all things, I think, is the best recommendation, and just kind of follow it. Sometimes it's an opportunity in some patients to introduce another therapy, like a thiazide if they need that, or an SGLT2 inhibitor, because those interventions, if taken along with ACEs or ARBs or MRAs, actually can appear to mitigate the risk of hyperkalemia a little bit. So we worry about hyperkalemia a lot,
Right.
but it shouldn't prevent us, I think, from the delivery of guideline-directed medical therapy to most people.
Right. Go ahead, Amber.
No, I was going to say regarding the dosing, I think there is, at least in the heart failure world, there's data that some dose of the guideline-directed medical therapy like ACE or beta blockers are better than no.
Right.
So I think it's really important to have patients on the right drug, and then there may always be an opportunity to up-titrate it later on, but patients who don't get up-titrated are the ones who don't have the drug on board to begin with. And considering the inertia we see often in getting new therapies on board in our patients, particularly in our older patients or patients who have other comorbidities or maybe frail, I think having lower doses of some of these evidence-based therapies is better than not having these therapies on board at all.
Yeah.
I think so too, and I think another really important point is to kind of turn a cold eye on the other medicines they're taking. And if, for
Right.
example, they're also on a calcium channel blocker for hypertension management, I mean, you try to decrease the dose or
pull that
even
off.
discontinue use of that one so you can safely up-titrate the dose of ACE or ARB, because there are many classes of antihypertensives that we prescribe to people for blood pressure management that don't have an evidence of an outcomes benefit beyond that. So we can be a little bit selective about making substitutions.
Yeah, I think that's a great point. And I always think that, sometimes you really, especially patients 80 and over, I do run into problems with tolerability. They have, long established CKD, long established hyperkalemia, and heart failure. So that can be a challenge. Try to keep something on board. And when I can't necessarily push that medication up to a higher dose, I'll think about, well, am I optimizing your statin? There's other ways that I can have an effect. Now there were some questions come in about GLP-1s and the use of that mechanism. So that could be another thing. So I really try to focus on some of those other areas, because it can be something like, we commonly see like hypertension or hyperkalemia. It may just be that the patient has this idiosyncratic reaction where they get severe GERD or constipation, et cetera, and they just refuse, I'm never taking that drug again. Try to work around that. You do have other options. So when one thing is not optimized, really that gives you an opportunity to optimize other functions that could help.
Exactly.
All right, cool. All right, I'm next. So I'm gonna have a case of type 2 diabetes, and you'll be able to tell that I've only worked in my professional career in a federally qualified health center. So how many of you work in FQHC or other similar safety net? Okay, good. This should be right in your wheelhouse. 72-year-old woman presents with type 2 diabetes for 20 years, presents for her first visit. She has hypertension, hyperlipidemia, obesity. These are the most common conditions in my practice. Has intermittent health care for chronic conditions from a number of different providers, gaps in health insurance coverage, gaps in keeping her appointments. And you see that her last appointment was with an outside clinic 7 months ago. Luckily, you actually have a record of that, at least with her labs. She presents with her daughter, and she has some fatigue, but otherwise feels well. She needs medication refills. That's really why she's here. She's on her last week of her current regimen, which includes metformin XR, empagliflozin, losartan, amlodipine, rosuvastatin, which you find out from your medical assistant she's actually not taking, aspirin. And then you see her vital signs there. Her blood pressure does not appear to be controlled at this time. Her BMI is 34. You see her labs from 7 months ago, mind you, there. You see their K is elevated. Her bicarb is a little low, and her creatinine is elevated. Her GFR is down. Her A1C is high at 8.8%, and she has some mild anemia as well. We don't have a urine study. Not unusual. So what's the next best step in caring for this patient? What's the next best step? Is to increase the dose of losartan, tell the patient she needs new lab work prior to prescribing refills for her own safety, initiate a discussion about GLP-1 agonist medication, or explore why she has not had more regular outpatient follow-up. Please mark your answers now. Whatever Heart Guardians is doing with their technique of looking around for the answer, it's working because you guys took the lead. So yeah, keep, something about the body movement, I guess.
I don't know, or maybe they're stretching out.
Oh, we get to see Iron Master. Iron Masters is the quietest one. Oh, so we're kind of split up here. I totally agree. And so this is really, I don't think the the answer is perfectly clear here. So sorry to ruin your game for you. But I think at the core of this issue is this is chronic illness over time. We're seeing its effects. We know that she has long-standing kidney damage. We know that we see multiple conditions that are not controlled today, between her diabetes and her hypertension. She's not taking a statin, which is she's on foundational drugs, at least some of them are foundational for her, yet she's either not taking them or missing appointments. And so I would say that increasing the dose of losartan is fine. New lab work is very important, and I know that was the winner in terms of the polling. GLP-1 could certainly be a good candidate for that as well. Heart, kidney, and diabetes healthy there, so really hits all the targets. But I feel like exploring a little bit more about what's going on with her follow-up. I think this is a time really where I'm going to let's take ownership and see what we can do. Because over the long term, if she's missing appointments and just getting care every 6 to 9 or 12 months, that's really we're not going to maintain her on optimal care no matter what intervention we do today. Oh, did I go too far? Yeah, go ahead.
Can I just make a
Please, yeah, this is a discussion.
About the case. So I did notice that she's prescribed empagliflozin 25 milligrams a day, and she's got an eGFR of 36. It's important to know that the cardiovascular and kidney outcomes benefits were associated with the lower dose of EMPA, 10 milligrams. And also, there's no need to go up to 25 milligrams in her since she has an eGFR of 36. Probably the drug's having very little to no effect on her blood sugars at all. And so one of the things that could be very cost-saving is just have her split the pills and take half a tablet a day. In fact, that's a nice way for people to save some money. And often that's an intervention that's welcomed. So once the eGFR gets below about 45 or 40, then the outcomes benefit is still provided by use of the SGLT2 inhibitors, but it's probably not doing much for blood sugar control at all.
Yeah, that's a really good point. And I don't disagree with her regimen too much, but Ambrish, what do you think about the use of aspirin in a 72-year-old with this history? Yeah, I think she has no cardiovascular events that I see on her record.
Yeah, I think that's an important question. And I think this has been studied, aspirin for primary prevention in diabetes. The data has been kind of wishy-washy, mostly heading towards the null finding. I think Ascend was the trial that was published in diabetes. Then Esprit and other trials have been done in general primary prevention setting. In my mind, I think there's less value in terms of getting primary prevention aspirin in patients. So I think I would say a statin would have been great, and she hopefully was taking it. But if you are worried about polypharmacy, if you're worried about the risk of bruising, bleeding, I think those things, you can think about aspirin may not be as relevant. Aspirin does have some benefit in other domains, I think, which may be also warranting closer consideration. But for primary prevention of cardiovascular disease, aspirin is not really currently our best choice, because there's so many other things you can do in this person for optimizing their cardiovascular risk reduction. Yeah, I mean, for primary prevention, aspirin, if you have diabetes and other cardiovascular risk factors, that probably is where you're going to get the most benefit. But when you're after age 60, your risk of bleeding is now substantially elevated. 72, where she's at, it's very substantially elevated. And if she's having trouble, keeping all her medications, I would say the rosuvastatin here would be much more important. But so there's a lot of details, right? There's a lot of different avenues. So I decided to put it, kind of in these themes. So because there's so many things we could do for her, it becomes a challenge of just where do you start? Should we try several things at once? Because we can ameliorate a bunch of things. We can put all those answers in. We could start GLP-1 and increase the losartan and check on and pull the aspirin and lower EMPA all at once. But could that actually move us further from our goal, because we're just creating some more confusion in our 15 or 20-minute visit that we have? And then there's the issue of do no harm. Most folks really want it, or there's a good percentage that want another lab. Patients who are getting these medications without any monitoring, that presents a risk. And she has hyperkalemia already. That's established. She has some fatigue. Could we be making that worse with more medication? So that's a question. So I really want her to get new laboratory work. But how do we ensure she gets it? Maybe giving her too many changes. So
I tend to think most folks are incrementalists as patients and with chronic disease. So you try to do 7 things, how many might get done? 0. You try to do 2 things, maybe you get 1 done, and that's you just have to take that. But the key is make sure you get follow-up, because otherwise we're just whistling in the wind. That means that how do we know that the changes we're making are actually substantial, and it's going to be something that moves the care forward. Now, it may look good because we're now meeting the guidelines, but if it does not apply to this patient, if we know that because she has transportation issues, she has fear of these medications, she doesn't understand her diagnoses, she's having side effects. So I think that would be the time well spent, is just to understand what is causing this intermittent care. And I hear everything in my practice, right? We've all heard various reasons, and they're all legitimate, but I think it starts with understanding. So I think that that's where I'd spend most of my time at this visit, and then using that information, that will help me. Okay, here's the paths that we should pursue. I think new laboratory work is great, but I think that establishing a better care system for her and really making her feel welcome and cared for, and that we are there for her, is critical. This is what we do really well in primary care. So I'd welcome, go ahead and put any comments in on the chat, but I'd welcome any comments based on that, and how you feel as specialists. Is that something you see, and what you might think of that?
Yeah, I think you're exactly right. I see patients at Parkland Hospital in Dallas, which is a safety net hospital, and so this profile of patients come to us in cardiology clinic all the time. And for my first visit, I often have this rule that simple is complicated and complicated is impossible. So if you're seeing the patient for the first time, make sure your approach is really simple, and the idea should be fact-finding, understanding more why they have what they have, what is the true driver of their lack of care access. And as you correctly said, I think if you try to change too much, patients don't have the trust established, patients don't have the rapport with you, and they may find it overwhelming to really accommodate all this in the first time they see you. So often my first visit is focused on, like you said, understanding what has been the driver of their care so far, what is important to them, what do they want to accomplish from this relationship, and how can we start building towards that, rather than just trying to be over-prescriptive about evidence-based therapies, 5 of them all at once. And so I think that's, I completely agree with your approach.
So I'll just share a quick story that I tend to be very positive in clinic. I try to really be encouraging. I emphasize that these drugs have been shown to make people live longer and live better. You're healthier, you'll feel better, you'll have less disability. And so I tend to come in with pom-poms up and ready to go. And so one of the exciting things in my practice, I'm sure you've seen this in yours over the last few years, has been with type 2 diabetes management, is I see a patient, I saw a patient on glyburide and metformin as their only drugs, and they weren't controlled. I'm like, boy, do we have a deal for you, because in our center, managed care Medicaid covers GLP-1 agonists. It covers SGLT2 inhibitors. And so I went in there and I was like, oh, great. Well, so these drugs are healthy for your weight, and they can help your heart and kidneys at the same time beyond the glucose reduction. And they're also very good at glucose reduction. So I was super excited, and he's just kind of sitting there and I was trying to read him. It's like, he's not buying it. I'm like, okay, well, what's going on here? He's like, well, I really want to go back to my regular physician and see this, because I just don't think that this is for me. And it was just interesting to see, and why? Because they had trust. They had trust in the other physician, and I had not come in there. I came in there a little bit too guns a-blazing, and I realized my approach failed. So I left a note. Luckily, it was still in our center, so I left a note saying, hey, you may want to consider at the next appointment, because I saw that it would take that appointment 2 months down the road is really where they were going to get that information, and then hopefully move to a regimen. But I mean, it is such a hopeful time, because we used to not have medications for HFpEF and chronic kidney disease. Now we really want to to advance care, because it's associated with better outcomes. But you can't just push all the levers forward. On the Millennium Falcon across the street here at Disneyland, you can't just push the things forward and go into hyperspace for most folks. Most folks need a more individualized and, I think, careful approach, and that can often win the day.
And I don't want to completely ignore the fact that she has an A1C of 8.8%, but I think when you're just meeting someone, it is important not to overreact. And so given what you've told us about this particular person,
I would be concerned that that value might be high because they've only had intermittent use of the medications, either because they couldn't access them, their prescriptions expired, or maybe they're not tolerating the medications particularly well. And people will not tell you that right off the bat. You have to kind of make it a safe space. Most of the time, the conversation that I have about use of medications relates to insulin, and I will say to people, I know that everybody misses some of their insulin doses, for example, and in an average week, how many doses do you think you likely miss? And some people will say, I'm not taking half of them.
Right.
And so that's important, and if somebody tells you they're not taking the medication half the time, it's time to take a step back, because that's not working, it's not going to work. You can't just keep hammering at the same door. You've got to take a step back and kind of figure out what that person will be willing to take on a consistent basis, and it will probably be de-intensified. So don't forget, take a visit or two, maybe don't let her go a really long time until the next appointment, but get her on her medicines consistently. If she's not tolerating metformin, which a lot of my patients do not, then you could switch her to something else at today's appointment. But it is important not to overreact. We see all kinds of people prescribed huge doses of insulin in the outpatient setting. They come into the hospital, they're put on that same dose, and they have terrible hypoglycemia. They're not taking the insulin at home. Right? So we always need to have in the back of our mind the importance of exploring whether or not that might be part of the presentation.
Yeah, patient-centeredness. It doesn't happen a lot, but it's always interesting when I say, I would love to see you back in 6 weeks. How about a year? Okay. How about 3 months? How about 9 months? And then we just kind of keep moving. We're going to end up at 4 months, aren't we? We're going to end up, 4 months. It's not ideal, but again, document all that. Document everything that you do, and that shows that you went out of your way to provide the best evidence-based care, but it's really based on after mutual discussion with the patient, they decided this. All right. Let's get to our last case.
All right.
Thanks for your help.
We'll talk about the heart failure case now. So let's go to the next one. So we have a case like the other two sections of a 68-year-old female with obesity, BMI of 35, who's presenting with progressive symptom of shortness of breath with exercise or dyspnea on exertion. The clinical data that we have available, this could be a patient in my clinic tomorrow actually, and then the echocardiography shows ejection fraction of 56%, left atrial volume is a little elevated, and the E by E prime is a measure of the diastolic function, it is normal at 8, NT-proBNP is around 120, remember the cutoff was 125, she has paroxysmal AFib and she's taking 2 blood pressure medicines for controlling her blood pressure, and let's assume her blood pressure is reasonably well controlled. So the question here is, in the setting of her signs and symptoms of dyspnea on exertion, what is the best next step for diagnosing patient with HFpEF? And I think the options are diagnose HFpEF based on the preserved ejection fraction on the echo and the signs and symptoms of heart failure with dyspnea on exertion. Use the help of a score, which is one of the scores is H2PF score, and based on that, we can diagnose it in the setting of an NT-proBNP not meeting the threshold of 125, and then proceed with further workup. Rule out HFpEF because then NT-proBNP is actually below the threshold that we talked about, or attribute her symptoms to obesity and deconditioning and not do any further cardiac workup. So please mark your answers now, and let's see what it shows. I was hoping the heart guardian would look more confident for this one, but I guess not. All right, I think you guys have got it right again. 87% got it correct, which was to pursue a more systematic workup, starting with a clinical risk score, then stress echo and other testing to confirm presence of stiffness in the heart or elevated filling pressures. And we'll go over this in detail in the next slides. Let's see. So here's the overall approach to when I see a patient with signs and symptoms that may be suggestive of heart failure, like dyspnea on exertion, swelling in the legs, or things like that. I think one of the first things that we want to understand is whether their ejection fraction by echo is above or below 50%, because that identifies 2 different forms of heart failure. So if the ejection fraction is under 50%, you have your answer. It's heart failure with reduced ejection fraction, and there are several therapies that are available for us to treat this patient. The bigger challenge is when the EF is on the normal end, so it's 55%. Now, it's not HFrEF, But does it mean that it's HFpEF? That's not the case. So there is a much more workup that is needed to further establish the diagnosis of heart failure with preserved ejection fraction in patients who may have signs and symptoms, but the ejection fraction is 55%. And so it could be a variety of things, and it could be basically heart failure mimics, which are conditions that present with similar clinical presentation like shortness of breath, and it could be obesity, lung disease, deconditioning. It could be a cardiac issue, but not necessarily HFpEF, like valvular heart disease, moderate to severe or severe aortic insufficiency, mitral stenosis, infiltrative heart disease like sarcoidosis, amyloid, hypertrophic cardiomyopathy. They all will present with similar constellation of signs and symptoms, but have very different management approaches. So all cardiac causes of shortness of breath and a normal EF does not amount to HFpEF. So HFpEF is actually a specific diagnosis and needs further workup to understand and confirm the diagnosis. So if we look at the definition of heart failure refers to reduced capacity of the heart to pump blood to the body at the rate commensurate with the needs of the body at rest as well as with exertion at normal diastolic filling pressure. The idea is it is able to meet the needs of the body at rest as well as with exercise without putting too much stress on it, which is measured by the diastolic filling pressure. And the gold standard diagnosis is invasive hemodynamic exercise testing, which is basically referring to measuring the pressures in the heart when the patient is exercising to confirm that they are able to meet the requirements without increasing the pressures in the heart. A simpler way to predict or confirm diagnosis of HFpEF has been developed by the Mayo Clinic colleagues. They used a cohort of patients who had invasive gold standard testing done and developed this simple risk score. This could be really helpful in your primary care clinic, in medicine wards, family medicine wards. So this is the H2PEF score, which includes BMI, blood pressure, atrial fibrillation, pulmonary hypertension, age, and filling pressure by echo. And if your score is over 6, the likelihood that you have HFpEF is much more higher. And that simple score has been very helpful in a lot of outpatient settings, a lot of internal medicine wards to determine the diagnosis of HFpEF. There are more complicated scores also available. This is from the European Society of Cardiology. It's called the HFpEF score. I'm not going to go into too much details, but it includes additional biomarker levels like NT-proBNP. It includes more echocardiographic data like strain. But at the end of the day, it gives you a score-based cutoff as well. So 5 or higher points means HFpEF. If it is between 2 to 4 points, then it means it needs further workup. So this is the algorithm that I often use, and I propose and help my colleagues in primary care and internal medicine to use as well. So if your EF is more than 50% and you have suspicion for HFpEF, you can implement the H2PEF score or the HFpEF score. If your score is at each end of the spectrum, you can rule out if it's less than 0 or 1. You can rule in if it's over 6 to 9 for H2PEF or 5 and 6 for HFpEF. But if it's intermediate probability, that's where you may want to refer them to a cardiologist for further workup. And the further workup includes echo with exercise. So the patient is pedaling on a bike and we are looking at the heart to look at their filling pressures and diastolic function when they are doing some activity. That gives us the assessment of their functional status, but also tells us whether or not they have impaired diastolic function with exercise, which can be contributing to their heart failure signs and symptoms and confirm the diagnosis of HFpEF. If you have impaired exercise capacity and you have increase in your stiffness with exercise, you confirm the HFpEF diagnosis. If you don't, you rule out the diagnosis. But there may be undeterminate or indeterminate testing in which we end up doing exercise invasive hemodynamic assessment. So I think from a primary care standpoint, using the risk score, confirming the positives or the negatives with the extreme scores, and then referring the patients who may have an intermediate probability for further testing is a good take-home message for these patients. So let's come back to our leaderboard for one last time and see who indeed won this competition.
This is it. Yeah, this is the big one. All right. So, ooh, that is close, but Hard Guardians did pull it out.
They did.
So congratulations, Guardians. You did a great job, everybody in the room. But yeah, everybody, thanks very much for participating in the game. It hopefully was interesting for you. It's always fun to watch for us. We love the animations, if nothing else. Yeah, all right, enough celebrating.
So happy.
Nobody. Well, I don't know how nervous you are. He looks. He's really flexing on the other teammates. There,
Yeah.
that's more like it. There you go. That's better animations. Let's all play along here. All right, we are going to do some questions. We have some time for Q&A, so if you got to go, I get it. But let's move into Q&A section now. We still have some time, so if you want to put in your questions, please do so. But definitely during credit, snap that QR code, and you can fill out the survey and analysis at the end. I think the most common question we received is compare finerenone versus older drugs, spironolactone and eplerenone with similar but slightly different mechanisms of action. What is the evidence in terms of efficacy and tolerability? Can you provide some insight?
Okay, I think we should both answer this, but I'm going to start. I'm going to start with the side effect profile, and then address the use of MRAs in kidney disease. So one of the ways that finerenone is very different from spironolactone and eplerenone is that it is non-steroidal, and it's also very highly selective for the mineralocorticoid receptor. As you know, primarily with use of spironolactone in men, the drug can cause a lot of sexual side effects, like in particular gynecomastia, which can be very problematic and in fact completely prevent use of the medication. Because finerenone is, again, non-steroidal, specific for the aldosterone or mineralocorticoid receptor, none of those types of side effects have been reported, to my knowledge, in any of the trials. So the drug appears to be better tolerated. Also, when it comes to the use of an MRA in patients with kidney disease to improve kidney-related outcomes and associated cardiovascular disease, there are no data for spironolactone or eplerenone. There's no evidence from trials using those agents that they actually have a beneficial effect on outcomes in patients with chronic kidney disease. So that's where finerenone is very, very different from what has been available in the past.
You want to go, Emery?
Yeah,
Because we know spironolactone has a strong role in heart failure with reduced ejection fraction.
Right, and even in HFpEF, it was studied in the TopCat trial, where the primary trial was negative, but there were a lot of issues with the trial conduct in, I think, Europe and Russia, and so the data didn't really tell us clear-cut evidence, and spironolactone had a 2B indication in patients with HFpEF till the and I think we were using it in HFpEF till Fine Arts came out, and now we have FDA-approved indication. Fine Arts was a definitively positive study, and generally, as Jennifer was saying earlier, the rates of hyperkalemia are lower. The Arts HF trial was a phase 2 study that compared head-to-head spironolactone with finerenone and showed lower hyperkalemia rates. And I think it's better tolerated from side effect profile. It has more robust evidence. So particularly for HFpEF and for diabetes with CKD, I think the evidence is overwhelmingly positive for finerenone, and it either doesn't exist for spironolactone or is negative. So, and even recently there was a trial called BARAC-D, which actually was testing patients with diabetes and CKD with spironolactone, and the trial was discontinued because of high rates of treatment discontinuation, which was over like 40%. So at the end of the day, I think if you have CKD or HFpEF with diabetes, I think finerenone is the only therapy that has available evidence. It's probably safer and it's effective. Spironolactone is a little bit unknown for CKD, and for HFpEF, the evidence is null in the overall trial.
Great, thank you so much. When should we screen with BNP folks with diabetes? Is it when they're diagnosed with type 2 diabetes? Do we wait in type 1 diabetes? Any insights?
So I think for type 2 diabetes, I think at the time of diagnosis is reasonable, because often type 2 diabetes diagnosis date doesn't mean that's when the disease started.
Correct.
Patients have had the disease for a while, and everything that causes the kidney disease, the same inflammation, the same pathophysiological abnormalities also cause the increased stiffness of the heart failure risk. So screening, in my mind, and the ADA, American Diabetes Association, had come up with a position statement, I think a couple of years back, where they did recommend NT-proBNP screening at the time of diagnosis, and at least repeating it yearly if negative, to track the risk of heart failure, and using that data to implement evidence-based therapies, because the same therapies that work really well for kidney disease, for diabetes, also work really well for preventing heart failure and treating early heart failure. So they are SGLT2 inhibitors, GLP-1, finerenone, and this spectrum of cardio-kidney-metabolic disease is really captured and I think addressed by these therapies. So I think the more avenues we can have to identify these conditions early and to implement these therapies early, the better it is for the patient population.
Yeah, well, that's why I get so excited and overly excited sometimes, as I described. Yeah, there's a lot of great options out there now. So one of the worst complication I can think of with use of ACEs and ARBs is the risk of angioedema. While rare, we have 2 questions on it. Can you initiate ACE, or is it recommended to initiate ACE or ARB retrying therapy in history with a patient or a patient with a history of angioedema? I would say if it was specific to ACEs and ARBs, then absolutely not. Any other? Yeah.
No, but
it's a no-fly zone.
Yeah, I wouldn't have any concerns about cross-reactivity to something like finerenone. There's no evidence that would occur. You definitely, if they've had angioedema with an ACE, you don't want to try another ACE. Even trying an ARB is controversial in someone like that. So you're treading on thin ice if you're going the ARB route in somebody who definitely had angioedema with ACE use.
And this is, I think, one of the reasons that we see low rates of urine testing overall it's part of a marketing issue. Is it proteinuria? Is it UACR? Is it testing for microalbumin? You know, these terms seem kind of mixed together, they're conflated together even though they're slightly different. But there was a good question about what exactly should be testing for. UACR is really the standard.
Well, but if your lab, calls it urine microalbumin, or if your lab only provides you with urine protein to creatinine ratio, do it. The most crude instrument would just be a urine dip.
Yeah.
And then you're going to catch people when the protein is positive. You're going to catch people further along the road. But if you're in a really constrained environment, you can use any of those tools and to make the diagnosis.
I mean, I work in a pretty constrained, I think we all work in pretty constrained environments, but I think UACR has really been adopted as a standard over the last decade. So I would hope, that'd be interesting to me to learn, if that's still an issue, but
I think it is. I mean, my lab calls it a urine microalbumin. And I don't call it that, but that's the orderable test. And I agree, I think it is confusing.
It is, and unfortunately that leads to less people getting the right test.
So I don't know, I don't want to waste
It's really
money,
a bummer.
Right?
Let me see if there's anything else for us right now. And feel free to keep them coming in. What about SGLT2 inhibitors, elderly patients, HFpEF, but they have a history of urinary tract infections?
That's an important question, and that comes up quite often actually in my practice. And it's really important to understand what the evidence is for genitourinary infections with SGLT2. It's mostly for mycotic infections and genitourinary mycotic infections. So a simple UTI that is treated by amoxicillin or Cipro is not really a contraindication. It's not something that should deter us from using the therapy. If someone develops a UTI during the therapy, you can consider stopping it, but you should always think about restarting it, knowing that it may be true unrelated. But I think there is a lot of skepticism among patients as well. They read about it on Google and they become really worried. So I actually have a very balanced approach. I often tell them about the risk. I often educate them on the need for maintaining a good genitourinary hygiene. And I think that can actually prevent it to begin with.
Yes.
And I think a lot of the risk is related to extra sugar that is peed out in the urine. And I think a lot of HFpEF patients without diabetes don't do that. So I also educate them on what causes it. And then if I encounter any such instance of UTI that's not mycotic infection, then I always try to restart it if I can.
Yeah.
If I could make a couple comments.
Yeah, please.
I'm just going to provide, there are a couple scenarios in which the SGLT2 inhibitor might not be the best choice. So we all have patients, for example, with incontinence. If I have a patient who's sitting in a wet diaper all day, every day, the SGLT2 inhibitor might not be the next best step. Those are the patients who are at risk for Fournier's gangrene anyway. And so in those patients, the good news is we have other options to treat their cardiovascular and kidney disease. We can go the finerenone route. We can go the incretin-based therapy route. So we may want to go a different direction first. Now I forgot what I was going to say. The other is the GU infections and UTIs. Again, I have some patients in my clinic, for example, they've had prostate cancer, they've had extensive kind of reconstructive surgery of their urinary tract, again, and they're already having recurrent and or chronic UTIs. Again, we may want to go a different direction first in those patients. It's always within our purview to exercise
good clinical judgment for the person who's sitting in front of us, and there will be exceptions, but the problem is the vast majority of people can take these drugs safely and aren't receiving them.
And I think my only pearl to add is, which is basically what you just said, always check on urinary symptoms before prescribing these, because many patients won't bring up the fact that they have urgency and incontinence. And then also, if they're on a thiazide, if they're taking furosemide because of, say, venous insufficiency, cut that out and replace it with the SGLT2 inhibitor, because that's actually going to have a better effect for them. And it's a mild diuretic effect, but I agree with HFpEF. They're not used to the fact of having that effect, and so they could be more of a transition. Usually, that is something that they don't even notice after taking it for 5 or 7 days.
Agree.
This was a great job. Thank you very much to both of you. So applause for our excellent panelists, and applause to you for participating. Those of you stuck it out to the very end,
Yes.
we appreciate you. Thanks for everybody online as well. Take care, everybody. Have a great conference.
Thank you.